The posterior apprehension stress test is used to check for potential posterior glenohumeral joint instability. To perform the test, bend the elbow and flex the shoulder to 90 degrees in the plane of the scapula. Apply and maintain pressure down through the humerus and then adduct and internally rotate the arm. A positive test is indicated by apprehension or pain and possibly a click as the humeral head slides over the posterior glenoid.
This is going to be a video on the active compression test of O'Brien to diagnose SLAP lesions. Hi and welcome back to Physio Tutors. According to a meta-analysis of Hedges et al. In the year 2012, the active compression test of O'Brien has a sensitivity of 67% and a specificity of 37% in the detection of SLAP lesions. Therefore, the use of this test in clinical practice is at least questionable. The active compression test is really similar to the speech test. To perform the test, have your patient flex the shoulders to 90 degrees and bring them into 10 degrees of adduction. Now ask your patient to fully internally rotate and ask him to resist downward pressure. Okay. For the second testing position, ask your patient to fully externally rotate so that his palms are facing the ceiling. Now give downward pressure again and ask him to resist. Okay. This test is positive for a SLAP lesion if the pain that is provoked during the first testing position is lessened or disappears in the second testing position. Green et al. From the year 2008 have criticized the anatomical basis of this test as the second testing position produces a higher EMG activity for the biceps compared with the first testing position. In a SLAP lesion, you would therefore expect this test to be the other way around, as more biceps activity should in theory also provoke more pain at the origin of the long head of the biceps. Other tests that perform better in the detection of SLAP lesions are the biceps load 2 test or the Jurgensen's test. You can watch these videos by a click on the respective end card right next to me. Okay, this was our video on the O'Brien's test for SLAP lesions. I hope you enjoyed this video. If you did, give it a thumbs up. Don't forget to subscribe to our channel and check us out on Facebook, Instagram or on our website. Until then, bye.
The apprehension test assesses anterior glenohumeral instability. Ensure the patient is close to the edge of the examination table. Then, move the shoulder into maximal external rotation in abduction. The test is positive if the patient states they feel the joint is unstable or if they experience pain in this position.
This is the sulcal sign for inferior shoulder instability. A positive sulcal sign can be an indication for inferior shoulder instability or glenohumeral laxity. Be careful though if your sulcal sign is present on both sides, as this outcome is not as clinically relevant like only unilateral laxity on the affected side. To perform the test, have your patient in standing position with relaxed shoulder muscles. Then grab your patient's arm distally to the elbow joint and pull the arm distally. The sulcal sign is the appearance of a little dip under the acromion or the feeling of subluxation, which is not the case in this patient. Okay guys, this was the sulcal sign for inferior shoulder instability. I hope this video was helpful to you. If it was, give it a thumbs up, share it if you like, and make sure to check out our other videos on shoulder instability, like the load and shift test or the Miniaki test. So see you next time. Bye.
In this video, we are going to perform the AC shear test for acromioclavicular pathology. Get our very own assessment ebook and mobile app. Links are in the video description. Hi and welcome back to Physio Tutors. The acromioclavicular shear test is a provocative test aiming to identify isolated AC joint pathology. As the test has not been subject to diagnostic accuracy studies, not much can be said about its validity, which is why the clinical value of this test remains questionable. To conduct the test, the patient is in sitting position. You're going to stand on the symptomatic side and then place the heel of one hand against the scapular spine and the heel of the other hand against the clavicle, and cupping the hands over the shoulder. Then squeeze the heels of both hands together. A positive test will result in abnormal movement at the AC joint and possible pain provocation. Okay, if you found what you were looking for, make sure to give this video a thumbs up. We highly advise you check out our video on a cluster of tests for the AC joint by clicking or tapping on the left. Before you leave, make sure you are subscribed to our channel. If not, just click the button down below, as this helps us out a lot. Check the video description for useful links. And as always, this was Andreas from Physiotutors. I'll see you in another video. Bye.
In this video, I'm going to show you how to do the crank test to diagnose slap lesions. Get our very own assessment ebook and mobile app. Links are in the video description. Hi and welcome back to Physiotutors. Gismervik et al. In the year 2017 performed a meta-analysis of shoulder tests for slap lesions and found that the crank test had a sensitivity of 46% and a specificity of 72%. For this reason, the crank test has a weak clinical value in the detection of slap tears. The crank test can either be conducted with the patient in sitting or supine position, like in this example. Then bring his shoulder into 160 degrees of elevation in the scapular plane and flex the elbow to 90 degrees. Then apply an axial load with one hand and bring the patient's shoulder into repeated internal rotation followed by external rotation in an attempt to pinch the torn labrum. This test is positive in case of clicking with or without pain or apprehension by the patient. Alright, I hope you enjoyed this video. If you want to learn the most accurate test in the meta-analysis by Gismervik, check out our video on the compression rotation test in the video right next to me. Thanks a lot for watching. Please give this video a like before you leave. Don't forget to subscribe to our channel if you haven't yet, and follow us on various social media platforms. This was Kai for Physiotutors. I'll see you next time. Bye.
The near impingement test is used to detect the presence of shoulder impingement syndrome. This test is also called the passive painful arc maneuver, or simply the near test. With the patient's shoulder internally rotated, place one hand on the shoulder to limit scapulothoracic motion, and then abduct the shoulder slightly and elevate the arm through the scapular plane to its maximum range. If the patient experiences pain over the anterior or lateral deltoid, the test is considered positive and suggests subacromial impingement. This indicates that the rotator cuff tendons, or the subacromial bursa, are being compressed between the greater tubercle and the anterior inferior surface of the acromion. The supraspinatus tendon is the most common structure involved. The severity of the impingement is determined by the angle of the arc at which the shoulder becomes painful. Pain at 90 degrees is consistent with mild impingement. Pain at 60 to 70 degrees is consistent with moderate impingement. And pain at 45 degrees or below is consistent with severe impingement.
This is going to be a video on the Hawkins-Kennedy test for shoulder impingement. Hi, and welcome back to Physiotutors. The Hawkins-Kennedy test is a commonly used test in the assessment of shoulder impingement. According to a big study done by Hadjidas et al. In the year 2012, the sensitivity is at 80% and its specificity is rated at 56%. To perform the Hawkins-Kennedy test, have your patient in sitting position. Elevate the arm to 90 degrees of forward flexion and have it rest on one of your arms. Then perform passive internal rotation. A positive test is the provocation of pain. If your patient has pain during the test, this can be an indication of a subacromial impingement. The test will be negative in a patient with an internal impingement. Alright guys, this was the Hawkins-Kennedy test. I hope you enjoyed this video. If you did, make sure to give it a thumbs up, favorite it and share it. Subscribe to our channel if you haven't. All the links are in the description down below. Leave a comment if you want to know something else. This was Andreas for Physiotutors. I'll see you next time. Bye. During this video I was talking about different types of impingement. If you want to learn more about that, make sure to check out our theoretical video on shoulder impingement right here, and another test on how to assess shoulder impingement right here.
In this video I'm going to show you how to perform the Jurgensen's test for pathology of the long biceps tendon as well as slap lesions. Hi and welcome back to Physiotutors. The Jurgensen's test was primarily designed to test the transverse humeral ligament, which holds the long biceps tendon in the bicipital groove. According to a research done by Micharoli et al. In 2015, it has a sensitivity of 32% and a specificity of 88% for biceps pathology. Furthermore, a research done by O et al. In the year 2008 showed a sensitivity of 12% and a specificity of 87% for slap lesions. To perform the test, have your patient's forearm flexed to 90 degrees in full pronation and stabilized against the body. Then ask your patient to perform supination and resist the movement. At the same time, make sure that you palpate the biceps tendon in the bicipital groove. If you feel the biceps tendon popping out of the groove, this indicates a tear of the transverse humeral ligament. Tenderness or pain without the pop is indicative for biceps tendinosis or slap lesions. Alright, this was our video on the Jurgensen's test. Make sure to check out our other videos on biceps pathology or slap lesions, which are the active compression test of O'Brien or the Speeds test, which you can find on the left. As always, I hope you enjoyed our video. If you did, give it a like. Check us out on Facebook, Instagram, or on our webpage www.physiotutors.com. This was Kai for Physiotutors. I'll catch you next time. Bye. In this video I'm going to talk about the Speeds test for biceps pathology. Get our very own assessment ebook and mobile app. Links are in the video description. Hi and welcome back to Physiotutors. Originally, the Speeds test was designed to test for tenosynovitis of the long biceps tendon, but is now being used for several pathologies of the biceps. In their meta-analysis from 2012, Hedges et al. Found a sensitivity of 20% and a specificity of 78% for the Speeds test in the detection of slap lesions in the shoulder. The test scored equally low in the detection of biceps tendinopathy in several other diagnostic papers. For this reason, the Speeds test has a low clinical value to in or exclude slap lesions or other biceps pathologies. The literature describes two different performances of the Speeds test. For the first version, ask a patient to extend his elbow and fully supinate the forearm. Then the patient flexes his shoulder from 0 to 60 degrees while the examiner gives resistance. This is probably how Spencer Speed discovered the test himself, as he was experiencing pain in the shoulder when he was performing a straight leg raise test in his patients with an outstretched arm. In the second version, which is the version that is commonly used nowadays, the patient is asked to extend his elbow, fully supinates his forearm again and brings his shoulder into 90 degrees of flexion. In this position, the patient is asked to resist downward pressure. When a patient's arm is placed in the examining position for the Speeds test and downward pressure is applied, the biceps tendon acts like a suspensor cable from its insertion on the superior labrum to the arm. Increased tension in this cable, and if inflammation is present, is thought to result in pain in the shoulder. So in both cases, the test is positive if your patient reports pain in the bicipital groove where the long tendon of the biceps enters the shoulder capsule. Alright, this was our video on the speech test. If you want to know a more accurate way of how to diagnose SLAP lesions, check out our video on the best test cluster for this pathology right next to me. Thanks a lot for watching. As always, feel free to click the like or share button if this video was helpful to you, or drop us a comment. If you want to have all of our videos in one product, check out our book or mobile app in the description down below. You can find more info about us on our website or on other social media channels. This was Kai for Physiotutors. I'll see you in the next video. Bye.
In this video we will demonstrate the MT-CAN test, also known as Jobe test for subacromial pain syndrome. Get our very own assessment ebook and mobile app. Links are in the video description. Hi and welcome back to Physiotutors. In the 1970s and 80s, Neer coined the term subacromial impingement syndrome. According to his theory, impingement occurs on the tendinous portion of the rotator cuff by the coracoacromial ligament and the anterior third of the acromion. We have made an elaborate video on this topic that you can check out later by a click on the link in the top right corner. According to a systematic review by Hedges et al. In 2012, the MT-CAN test had a sensitivity of 74% and specificity of 30%, which would only minimally alter the post-test probability of subacromial pain syndrome, and which is why we give it a weak clinical value as a standalone test. To conduct the MT-CAN test, the patient is in standing or sitting position. The arms of the patients are elevated to 90 degrees in the scapular plane. The arms are then fully internally rotated so that the thumbs point towards the floor. The patient is then instructed to resist downward pressure applied by the examiner. A positive test is indicated by weakness and/or pain of the affected arm compared to the unaffected side. Alright, thank you very much for watching. In order to increase the likelihood that your patient might have subs, Mitchner et al. Propose a cluster of tests that you can watch next on the left. Do you want all of our tests in one slick product? Then check out our ebook or smartphone app. In our online course, we dive deeper into several shoulder pathologies, so check it out at the link in the video description. As always, don't forget to give this video a like and subscribe if you haven't yet. This was Andreas for Physiotutors. I'll see you next time. Bye.
In this video, I'm going to show you how to do the drop arm sign to diagnose full thickness rotator cuff tears. Hi and welcome back to Physiotutors. According to a study done by Miller et al. In the year 2008, the drop arm sign has a sensitivity of 73% and a specificity of 77% in the diagnosis of full thickness tears of the supra and infraspinatus tendons. The post-test probability of a full thickness tear is therefore only moderately altered, which is why we assign this test a moderate clinical value. To perform the drop arm sign, have your patient in standing or sitting position and bring the affected arm into 90 degrees of abduction and external rotation passively. Then tell your patient to hold this position and release your supporting hand. This test is positive for full thickness tears of the supra and infraspinatus if your patient is unable to slowly control the downward movement. Thus the name drop arm sign. Alright, I hope you enjoyed this video and give it a like. Make sure to watch our video on the internal rotation leg sign, which is a great test for full thickness tears of the subscapularis tendon. Before you leave, don't forget to subscribe to our channel and follow us on various social media. This was Kai for Physiotutors. I'll see you in the next video. Bye.
In this video I'm going to demonstrate the valgus stress test for medial collateral ligament injury in the knee joint. Hi and welcome back to Physiotutors. The valgus stress test has been evaluated in a study by Harry Lane et al. They rated the sensitivity at 86% and the specificity was not reported. To conduct this test, have your patient in supine lying position with the legs fully extended. Now with your patient in supine position, instruct him to relax as much as possible during the test. With one hand, grab onto the lower leg just above the ankle joint, and the other hand is used to fixate the femur. Then, slightly externally rotate the tibia and perform passive abduction in the knee joint, and thus putting stress on the medial collateral ligament. You're looking for excessive gapping on the medial side and the reproduction of pain. Consequently, perform the same test with the knee in 20 to 30 degrees of flexion. Again, you're looking for excessive gapping on the medial side and the reproduction of pain. Take a look at this table, which lists all of the structures you would assess with the valgus stress test in either position. Alright guys, this was our video on the valgus stress test. I hope this video was helpful to you. If it was, leave it a thumbs up and subscribe to our channel by hitting the button above. If you want to learn something about the varus stress test, click right here or check out a cruciate ligament video right there. This was Andreas for Physiotutors. I'll see you next time. Bye. This is going to be a video on the varus instability stress test for radial or lateral collateral ligament instability in the elbow joint. Hi and welcome back to Physiotutors. Unfortunately, it was not possible to find any statistical data on the diagnostic accuracy of this test. To conduct the test, you can have your patient in standing position. With one hand, fixate the humerus and put it in external rotation. Palpate the radial collateral ligament. Flex the elbow to approximately 20 to 30 degrees and then apply an adduction or varus force. Usually you will find a tense ligament, though if you experience increased laxity, a change in range of motion, pain or a soft end feel, this indicates an injury to the ligament. Okay, this was our video on the varus instability stress test. As always, leave it a thumbs up if it was helpful to you, and also be sure to check out the valgus instability stress test right here, or check out the video in which Kai covers elbow joint play right here. This was Andreas for Physiotutors. I'll see you next time. Bye.
In this video, we're going to show you a quick method to test for medial epicondylitis, also known as golfer's elbow. Hi and welcome back to Physiotutors. This test is designed to maximally stretch and thus provoke all the muscles that originate from the medial epicondyle and that attach distal to the wrist. To perform this test, have your patient in a standing position, fixate your patient's humerus and palpate the medial epicondyle at the same time. Then passively supinate your patient's forearm, extend your patient's wrist and extend the elbow fully. Okay. This test is positive if your patient complains about sudden pain at the medial epicondyle. Okay, this was our video on medial epicondylitis, also known as golfer's elbow. If you want to get to know 2 tests for lateral epicondylitis, also called tennis elbow, check out the Cosen's test right here or the Mills test right here. As always, I hope this video was helpful to you. If it was, give it a thumbs up, hit the subscribe button above and check out our webpage at physiotutors.com, and I'll see you next time. Bye. This is going to be a video on the Mills test for lateral epicondylitis, better known as tennis elbow. Hi and welcome back to Physiotutors. The Mills test is designed to maximally stretch and therefore provoke the extensor carpi radialis longus and brevis. To perform the Mills test, have your patient in standing position and fixate the humerus while you palpate the lateral epicondyle. Then passively pronate your patient's forearm, flex the wrist and extend the elbow fully. This test is positive if your patient complains about sudden pain at the lateral epicondyle. Okay guys, this was the Mills test for lateral epicondylitis. If you want to get to know 2 other methods on how to test for a tennis elbow, check out the Cosen's test right here, or check out a 3rd method right here. As always, if this video was helpful to you, give it a thumbs up, hit the subscribe button above, and check out our webpage. This was Kai for Physio Tutors. I'll catch you next time. Bye.
Finkelstein's test is used to determine de Quervain's tenosynovitis. To perform this test, grasp the patient's thumb and hand and deviate them ulnarly. Alternatively, you can ask the patient to make a fist with their thumb inside their finger and ulnarly deviate their wrist on their own. A positive test will produce a sharp pain along the distal radius where the tendons of abductor pollicis longus and extensor pollicis brevis are located.
This is going to be a video on the Phalen's test to test for carpal tunnel syndrome. The carpal tunnel is a passageway on the palmar side of the hand that is enclosed by the flexor retinaculum, which spans from the pisiform bone and the hook of the hamate to the tubercle of the trapezius bone. It is already narrow by nature, as 10 different tendons and the median nerve pass through it. As soon as any of the structures swell or degenerate, this can lead to compression of the median nerve, which is then called carpal tunnel syndrome. The Phalen's test was described to have a sensitivity of 85% and a specificity of 89% for the diagnosis of carpal tunnel syndrome, according to research by Brüske et al. In the year 2002. To perform the Phalen's test, ask your patient to flex his wrists maximally and hold the dorsal side of his hands together for 1 minute. The test is positive if the patient experiences tingling in the thumb, index finger, middle finger, and the lateral half of the ring finger, which indicates carpal tunnel syndrome by pressure on the median nerve. Okay guys, this was the Phalen's test to test for carpal tunnel syndrome. If you want to get to know another method to test for carpal tunnel syndrome, check out our video on the Tinel sign right here, or check out another test for the hand right here. I hope this video was helpful to you. If it was, give it a like, subscribe to our channel if you haven't, and check out our webpage at physiotutors.com. This was Kai for Physio Tutors. I'll catch you next time. Bye. This is going to be the Patrick's test, also known as Faber or Figure 4 test for limitation of hip range of motion. To perform this test, have your patient in supine position, then cross the test leg over the other leg above the knee. Make sure that the ankle is free and is not supinating. Fixate the opposite ilium and then slowly lower the test leg down to the treatment table. This test is positive if the test leg remains above the opposite leg, which can be an indication of an affected hip joint, SI joint, or iliopsoas spasm. Alright guys, this was our video on the Patrick's test. I hope this video was helpful to you. If it was, give it a thumbs up, subscribe to our channel if you haven't, and make sure to check out our video on the cluster of Laslet if you suspect an SI joint problem by clicking right here, or check out our video on hip joint play. See you next time. Bye.
The Scour test is designed to assess for hip joint pathology, including arthritis, labral lesions, and avascular necrosis of the femoral head. With the patient in the supine position, flex the involved hip to 90 degrees and bring it into adduction. Apply a long axis compression through the femur into the acetabulum, and while maintaining this pressure, rotate the hip internally and then externally. Now abduct the hip, and while maintaining the downward pressure, rotate the hip internally and then externally. The test is considered positive if at any point during the maneuvers the patient complains of hip or groin pain, or if clicking or crepitus occurs. This test is described with a number of variations in its procedure and is sometimes referred to as the quadrant test.
FAIR test is used to identify sciatic nerve irritation caused by the piriformis. FAIR stands for flexion, adduction, and internal rotation, and is sometimes called the piriformis test. To perform the FAIR test, the patient should be positioned in side lying with the affected hip facing up and the hip and knees flexed to 90 degrees. The examiner should place one hand on the pelvis to stabilize while using the other hand to support the lower extremity. Perform the test by moving the supported leg into flexion, adduction, and internal rotation. Apply moderate overpressure to the top leg while stabilizing the pelvis with your opposite hand. The test is considered positive if the patient complains of pain in the buttocks or experiences pain radiating down the back of the leg. For more information on the FAIR test or other special tests, visit ptprogress.com/test or continue watching the rest of the playlist right here. Hey, if you found this video to be helpful and to the point, can you give it a like below? It really helps the channel so we can make more videos like this for you. Thanks for watching, and we'll see you in the next video.
Hey everyone, Paul from OrthoEvalPal. Today what I want to do is talk to you about the valgus stress test of the knee. As luck would have it, we have a young lady here who has a positive test. So, when you are assessing the medial collateral ligament and the medial capsule, it's important to do this just right. So if you are checking the capsule to see if that's holding well, you keep the knee in full extension. You basically put this hand on the lateral side of the knee. This one is stabilizing over here. And all you're doing is putting a little bit of a valgus stress. Now notice how it opens up a little bit. She does not have that on that side. So it tells me that she has a little bit of instability at that medial capsule. Now to test the MCL, we take the capsule out of the picture, we flex the knee about 20-25 degrees, and we do the same test. Notice the gapping, okay? One thing that's very important here when you're doing this test is that you don't let the hip rotate in like that, because that can be quite deceiving. You got to keep that femur nice and straight. The motion is coming from down here and you're just stabilizing with this hand. Okay, so we'll do it again right here one more time. And that's quite a bit of gapping. And that's a positive valgus stress test. So I hope you liked the video today. If you did, please give us a thumbs up. Be sure to subscribe because I have a lot of special tests coming up, and even with some patients with real diagnoses. Thanks again.
To assess the lateral collateral ligament, we will perform the varus stress test. Again, abduct the hip and flex the knee to 30 degrees. With one hand medially and the other hand around the ankle on the posterior aspect, provide a varus stress on the knee and assess for ligament laxity compared to the other side. To perform the Lockman's test, flex the knee to 20 to 30 degrees. Encourage the patient to relax their hamstring musculature. Firmly grasp the femur with one hand and with the other hand behind the proximal tibia. Firmly pull, displacing the tibia upon the femur, looking for the amount of anterior displacement and the firmness of the end point. It's always nice to compare it to the opposite knee, and if you get increased displacement or a soft end point, this usually indicates an ACL injury.
This is going to be the anterior drawer test to test for ACL tears. The anterior drawer test has a sensitivity of 92% and a specificity of 91%, according to a meta-analysis done by Benjamin et al. In the year 2006. These values are reported for a chronic situation, while the test performs way poorer in an acute situation. For the anterior drawer test, it is first recommended to exclude a PCL injury in order to avoid false positive results. So click on the video right here to watch the posterior sag sign, or click on the video right here to watch our video on the posterior drawer test. To perform the anterior drawer test, bring your patient's hip into 45 and your patient's knee into 90 degrees of flexion. You can fixate this position by gently sitting on the foot of your patient. Then palpate the joint line with your thumbs and try to move the tibia anteriorly in an explosive movement. This test is positive if the tibia translates anteriorly more than 6 millimeters or if you experience a soft and mushy end feel. This was our video on the anterior drawer test. If you want to check out other tests for an ACL tear, make sure to watch the pivot shift right here or the Lachman test right here. As always, I hope this video was helpful to you. If it was, give it a thumbs up. Check out our webpage www.physiotutors.com and I'll see you next time. Bye. This is going to be a video on the posterior drawer test to test for posterior cruciate ligament tears. To perform the posterior drawer test, have your patient in supine lying position and ask your patient to flex his hip to 45 and his knee to 90 degrees. You can fixate this position by slightly sitting on the foot of your patient. Then palpate the joint line and push the tibia posteriorly in an explosive movement. This test is positive if the tibia translates posteriorly more than 6 millimeters or if you experience a soft and mushy end feel. Alright, this was our video on the posterior drawer test. If you want to learn another way on how to assess for a PCL tear, check out our posterior sac sign video right here. Or if you want to assess an ACL tear, check out our anterior drawer test video right here. I hope you liked this video, and as always, if you did, give it a thumbs up, check out our webpage or subscribe to our channel if you haven't, and I'll catch you next time. Bye. This is going to be a video on the McMurray's test for meniscal damage. According to research done by Blythe et al. In 2015, the diagnostic accuracy of this test was as low as 63%, which means that only 63% of all the patients were correctly diagnosed by musculoskeletal clinicians. To conduct this test, have your patient in supine lying position with the tested knee fully flexed. Then, rotate the tibia medially and bring the knee into extension. You want to repeat this process a couple of times with a different angle of knee flexion in order to test the whole posterior aspect of the lateral meniscus. In order to test the medial meniscus, bring the knee into full flexion and laterally rotate the tibia. The anterior half of the meniscus is not as easily tested with the McMurray test because the pressure on the meniscus is not as high. This test is considered positive if your patient experiences clicking, locking or pain in the knee. Alright guys, this was our video on the McMurray's test. Make sure to also watch the Epley's test and the Tasserly test right here that also assess for meniscal damage. This was Kai from Physiotutors. See you next time. Bye. This is going to be the Epley's test for meniscal damage. According to research done by Blythe et al. In 2015, the statistical accuracy of this test was as low as 58%, which means that only 58% of the patients were correctly diagnosed by musculoskeletal clinicians. To perform this test, have your patient in prone position. Then fixate the tested leg with your own leg and bring the knee into 90 degrees of flexion. While you give this traction, perform lateral rotation of the tibia and medial rotation. You are looking for excessive rotation compared to the other side or discomfort. Then repeat the same procedure while you are giving compression. In this case, you are looking for decreased rotation or discomfort. If rotation plus distraction is more painful or shows increased rotation relative to the normal side, the lesion is most probably ligamentous. If rotation plus compression is more painful or shows decreased rotation relative to the normal side, the lesion is most probably meniscus damage. Alright guys, this was our video on the Apley's test. Make sure to check out the 2 other tests in our channel to assess for meniscal damage, like the Tessely test or the McMurray's test. And also subscribe to our channel if you haven't. This was Kai for Physio Tutors. See you next time. Bye.
Do a draw test, testing for anterior tibiofibular ligament. Okay, so hand onto the tibia and fibula, and I'm pulling the calcaneus and talus forwards, looking for laxity and any pain.
The talar tilt test is designed to detect ankle instability involving the collateral ligaments, most typically the calcaneofibular ligament. To perform the test, place the patient in the supine position with their feet free of the table. Grasp the patient's foot with one hand and stabilize their distal leg with the other. Now dorsiflex the ankle to the anatomical position and then invert the ankle. If the ankle inverts excessively, it indicates instability involving the calcaneofibular ligament.
In this video, I will show you how to conduct the syndesmosis squeeze test in order to determine a syndesmosis sprain. The syndesmosis is the interosseous membrane that connects the tibia with the fibula, and it can get injured with inversion trauma or exorotational dorsiflexion trauma. The estimated incidence is 1% of all ankle sprains according to the KNGF ankle sprain guideline. According to an RCT done by De Caesar et al. In 2011, the squeeze test has a sensitivity of 30% and a specificity of 94% in the diagnosis of syndesmosis ruptures. To perform the test, have your patient in supine-lying position and squeeze the proximal fibula and tibia together. Then apply the same compression at more distal places down to the malleoli. According to Nussbaum et al. In 2001, the length of tenderness above the lateral malleoli indicates severity. So the more proximal pain is felt, the more severe the injury. Pain during these compressions may indicate syndesmosis rupture, given that a fracture, contusion or compartment syndrome have been ruled out before. Alright guys, this was our video on the syndesmosis squeeze test. Make sure to also watch our video on the anterior drawer test for injuries of the anterior TFL, or watch our video on the external rotation stress test, which is another test for syndesmosis injuries. As always, I hope this video was helpful to you. If it was, don't forget to give it a like. Check us out on Facebook, Instagram or on physiotutors.com. This was Kai for Physio Tutors. I'll see you next time. Bye.